Hi, everybody, and welcome this afternoon. I just wanted to also acknowledge the traditional owners of the land that we're all on today, wherever we are, and the elders past and present. And I just wanted to set a bit of context, really. You can read the slides here, but the fact that our elders are deeply respected and their place in our society, I think, is really important contextual issue to understand. And it's probably become nowhere more obvious than in the COVID response. In actual fact, a lot of the reasons why Aboriginal communities closed, etc., for COVID, because they wanted to protect elders, and on the basis of that as well, a lot of our marketing around social distancing and taking care of communities around the COVID stuff's been very much directed at us as communities taking care of our elders. This is really important to us, and not just because of the usual things, like respecting older people, but they certainly carry language, knowledge, culture, ceremony, a whole lot of other things, and in other ways, like I've seen elders involved in massive community mortality events where there's been multiple deaths, and in horrible situations. But I've seen elders really make a difference, and it's hard to quantify that in their value to us as part of our population, part of our communities. So really important stuff. I think another thing that actually happened to me as well that may help as well is I was doing a talk at the men's group on one of the islands, and an old man that was in the hospital who'd had a fall, but had cognitive decline, just sent us a message just saying to all the young men, "Hey, I can't walk anymore, but I can still sing." And so this man was the songman for the tribe. And look, this doesn't, it's really important to understand how important our elders are, how important this population of people are, but also what they mean to us for a sustainable kind of culture and peoples in Australia. So really, really important stuff. As you know, as well, most people will know, with our kind of prevalence of metabolic syndrome, etc., we have a lot of vascular issues and a lot of insults to us during our lives, as well as kind of a higher level of allostatic stress earlier on as well. And I think there's another slide now, Eddie. Yeah. And the other stuff there that you can read, though, that it is important to note that there's very low rates of dementia secondary to alcohol, which is probably not what people kind of thought. The other thing is that childhood trauma increases the risk of cognitive decline and dementia. And so if you kind of have a look at that, and then have a look at, this work comes from the big adverse childhood experiences studies in the US. But if you apply that to the longitudinal study of Aboriginal children in Australia, you can kind of see that, the US study looked at 4 to 6 or more adverse childhood experiences equals worse outcomes as adults, cognitive decline later in life. But the Aboriginal stuff, like we're seeing much higher rates, as you can imagine, of early childhood experiences, bad experiences. So these are the kind of things like, domestic violence, substance abuse in the house, kinds of things. So the Western Australian Child Health Check, the last time that they did that survey that I looked, they had up to 20 adverse childhood experiences per year for these families, and they were sustained as over time as well. So look, that just sets a bit of context around this, but and some of the background. But I'll hand back to.
Thanks, Mark. So we're going to just introduce Aunt Molly, who's someone we're going to see across a few of these webinars. So Aunt Molly's 68 years old, and she lives with her son, Frank. And as Mark mentioned, she's got a number of health conditions and those midlife vascular risks, including diabetes, hypertension, and obesity. And again, with those adverse childhood events, she was taken from her family as a young child and as a member of the stolen generation. Molly and her son Frank visit the local health service while the Aboriginal and Torres Strait Islander health worker Karen meets them. Frank's worried because his mum's been forgetful and acting out of character. She gets angry when she wouldn't usually, including with her grandchildren, who she always used to love having around. And Karen, the health worker, also noticed that Aunt Molly's been missed several health checks recently at the health service, whereas she used to be a regular attender. So we've come back. So keep Molly in your mind, and we'll come back to her a little bit later on in the presentation. So today I'm going to take you through, to begin with, some of what dementia is, what cognitive impairment is, what are some of the different causes, and then talk a little bit more about from there about how we go about case identification and screening. It's important to realise that we often use memory as a little bit of a shortcut to thinking what cognition is, but memory is only one part of cognition. The other parts are things about language, about planning, about abstraction, about movement and purposeful movement. And so it's not just all about memory, but that's the thing we typically try and think about that confusion or that disruption in normal thinking as well. And it's important to realize that cognitive impairment is not a normal part of aging. It's something that we don't expect to see in normal, healthy aging. And the reason it's so important that we actually have a look at it is it might be reversible. We've got things like medications that we, as doctors, all too commonly prescribe that cause problems with your thinking generally. It can be a mood disorder, or it can be an acute illness, all of which can cause reversible causes. Or it might be that it's mild cognitive impairment, which is when your memory is worse than you'd expect from age alone, but it's not really impacting on your everyday life. It's not really stopping you being you and you doing what you'd normally be doing. And you tend to perform a little bit worse on some of the tests that we do, but it isn't necessarily stopping you doing and participating in a normal way. And then there's dementia, which is a progressive decline in cognition that impacts on your everyday life and isn't due to one of those other reversible or medical causes. And really, overall, they need quite a complex and careful clinical assessment to make sure we get it right. And this is a beautiful piece of artwork, which was done by Anna Dwyer, who was one of the Aboriginal research assistants on the original Kika study, which I think just gives an idea of some of those signs of dementia and some of what the other risk factors and causes can be. So what is dementia? Well, it's important to realise that dementia isn't a single specific disease. And I suspect in looking at the audience tonight, I'm preaching to the choir, but it really is an umbrella term for a variety of different conditions that can affect the way that your mind works. And it's important to realise that because it's not, again, as we said previously, a normal part of ageing. And, often we use the term, say, Alzheimer's disease synonymously with dementia. But of course, Alzheimer's is only one of the underlying causes. And you can see on that picture on the other side, really the differences between a normal, healthy brain and someone with a severe Alzheimer's disease that shows shrinkage and damage to the brain. But these important characteristics of dementia is that these conditions affect how the brain works and they progress over time. So they're different from time A to time B. And they impact, as we said, on memory, but also on some of those other things that we see with thinking, sometimes with language, sometimes with behaviors, sometimes with that planning and abstraction and sort of putting together those complex tasks and learning things to a new extent. And they can impact on your everyday life, the everyday function about what you do. And now it's important to realize there that there's a continuum even there, isn't there? That there's those more complex functions of managing your medications, driving a car, cooking. And then there's the more basic things of actually being able to get yourself dressed or mobilize or maintain continence. So, and also it's not a binary state. It's not like one day you can do something and the next you can't. There's often a loss of some of the quality of these everyday functions before you lose an absolute ability to do them. And it's also good to realize that sometimes the person with cognitive impairment might not be the best person to give you that history of cognitive impairment. And where it comes into is often that family or other carers or professional or informal carers may be the ones that notice that change. But there's some really good news in all this as well. I think, one of the things when you're talking about dementia generally is you can face a degree of nihilism from people. But one of the things that I think we've seen most in the last decade or so is that idea of prevention and that idea of a whole of lifespan impact on aging and dementia. And if you look here, that really up to 40% of dementia that we see in later life is potentially modifiable by impacting further down the stream. And this can be all the way from looking after mums and bubs through your childhood into your midlife before you hit aging. And there's important things in there as well, isn't there? There's around education. And as Mark mentioned before, that childhood trauma is a big impact as well. So if we can look at reducing those in childhood, look at those midlife issues, hearing loss is a big one. And this goes back to childhood as well, and some of the initiatives around looking at reducing chronic ear infections and the Deadly Ear campaign, and looking at reducing traumatic brain injury. And I think that the story of chronic traumatic encephalopathy and head injuries is one that's playing out more and more at the moment. And there's probably more to be told in that story. And then looking at managing those vascular risk factors. And, I'm always a bit anti just concentrating on risk factors and looking at deficits rather than looking at more enabling aspects of aging. But it's important to realize that there are things in there that we can definitely do something about. Now, when we look at types of dementia, I think, again, some of the take-home messages of the last 10 years have been around that the single disease dementia is probably less common an entity than we once thought it was, especially as we get older and we get multiple overlaps of these different conditions that on their own can cause dementia, but combined together can be even more impactful. Now, as I said before, Alzheimer's disease is often used as a synonym of dementia. And in fact, if you call dementia Alzheimer's disease, you'll get it right half to 2/3 of the time, either on its own or in combination with often things like vascular disease. So when we talk about vascular dementia, that's when we're talking about strokes or furring up the blood vessels towards the brain that, depending on the area of the brain that's impacted on, can cause similar symptoms. And we traditionally think of things like a stroke-related or vascular dementia as declining more in a stepwise manner. So you can have an acute event that gets things a lot worse, things stay stable for a bit, and then something else happens. Lewy body dementia, it makes up around about 1 in 10 cases on its own, and probably a few more in combination with the other pathologies, and is linked with Parkinson's disease, so movements disorders, a slowness of movement, sometimes a shake. So often a lot of fluctuation, so people can get worse on an hour-to-hour and a day-to-day basis. And they can be very sensitive to some of those centrally acting drugs that are used to sometimes treat psychosis as well. And people will often present with visual hallucinations and falls early on in the case. More common in younger onset dementia, but still seen throughout the lifespan, is frontotemporal dementias, which can impact on either behavior or language on the whole. There's 2 different subtypes. And these people can actually early on have relatively intact memory, but have significant problems with either expressing or understanding language, or sometimes with more florid early behavioral symptoms, and which are a little bit different from your straightforward, more Alzheimer's type dementia. As Mark and Dina have said before, alcohol-related dementia is actually a lot less common in Aboriginal and Torres Strait Islanders and is seen in similar proportions as you'll see in remote populations generally. So it's really not the main issue. And as I said before, that the head injury related causes of cognitive impairment are probably more common than we first thought. And I think that's going to be an evolving story. So why do we want to look at dementia in Aboriginal and Torres Strait Islanders? Why do we want to pick it up early? Well, there's an imperative to really making an early diagnosis to empower the person that is living with dementia. As Kate Swapper, who's a dementia advocate from South Australia, said, is there's often with a diagnosis this term of prescribed disengagement, but really the other way of looking at it is life doesn't stop when dementia starts. And by early identification, really we can work to try and slow down disease progress. And as you saw in that risk factor slide previously, by controlling and looking at treating those comorbidities, because often dementia is not the primary problem that someone will come into your health service with. It will be in association with a lot of these other diseases of aging. And by treating those vascular risk factors, you can slow down the progression of dementia, and you can also address those other quality of life issues. So make sure that you're dealing with the ability to people to discuss their preferences, to actually say what they want in terms of their care, both now and into the future as the dementia progresses. And by looking at what are the support services that will improve and support what is important to them, what is important to their quality of life, rather than something that's done to them. It's something that is driven by the person living with dementia and with them. It also gives the opportunity of helping support care partners as well, to make sure that we look at what their needs and supports in education. We know that people who are care partners for people with dementia have higher risk of illness themselves. They're often on more prescribed medications, and there's evidence that early interventions with education, which is where DTA is so important as well, will actually support carers and make sure that it reduces their level of stress and their adverse health incomes. And also the other thing is really, if you don't diagnose it early, you miss the causes that are truly reversible. Mood disorders, for example, will often not present as a straightforward younger onset depression, but might be around social withdrawal and memory problems and answering "I don't know" to questions, rather than the classical expressing a low mood. And that is a potentially treatable and reversible factor, as are a lot of the medications that we prescribe, especially some of the older ones that impact on the same chemicals which we find in lower quantities within the brain in diseases such as Alzheimer's. So case finding, as opposed to screening, is more about looking for disease in people with a high pre-existing risk. And we know that around 1 in 5 Aboriginal and Torres Strait Islanders over the age of 50 will have some form of cognitive impairment, and that dementia is between 3 and 5 times as common. So you're dealing, when you're looking at people over the age of 50, you really are managing a cohort of people with a significant risk of cognitive impairment. And so by looking at case finding, there's a couple of ways we can do it. One is the sort of observation side, isn't it? The sort of more passive side, where you're not necessarily directly going in and asking the questions, but you may have the person themselves, or a family member or a friend or another health professional might be raising concerns about that. There's been some problems recently with thinking, they seem to be a bit more confused, they're repetitive, their memory's a little bit worse. Or you might have observed this yourself. They might have missed a few appointments, like Aunt Molly. They might have had problems remembering the right medications to take. But if you're going to take the preferred option, which is a more active approach as well, that's when you try and have a look at some of those things around the risk factors and asking some of those targeted questions about memory and confusion. And we'll come on to those over 50 health checks and the 715s in a little bit. And if you've got any suspicions, that's when you go into cognitive screening. I have a bit of a 3 steps to diagnostic heaven, if you like. It's really, one, is there cognitive impairment? And that's where this comes in, either from the history, from a bystander history, or from the cognitive screening. Then, is it caused by dementia, which, as you see before, is it progressive? Is it impacting on everyday life? Is it not caused by something else? And then the third step is around what sort of dementia is it? So the annual health check, this is an important change, really, to look at adding in a more formal look at cognition for people over the age of 50. And this is where we can make sure that this goes into the software, such as Best Practice, Medical Director, Communicare, so that you've got this on the 715s. And just those 2 questions there. Do you have any worries about your memory or thinking? Does anyone in your family have any worries about your memory or thinking? And ideally, if it's yes to either of those, or if there is high risk, or if staff ages concerns, that's when you go on to do more formal cognitive screening with some of the tests that we do use on a common basis. So we talked before about some of the things that might give you a little bit of a clue. And I think, you know, if we take Aunt Molly, for example, the forgetting appointments, and again, the key with dementia is change from a baseline. You know, I mean, if I get dementia and can't play the piano, it's not because I've got dementia, it's because I've never been able to play the piano. So it's important to actually realise that it's change over time. And to look at the chronic diseases not being well managed is a really fascinating one, because you'll get someone who's on increasing numbers of tablets to treat their blood pressure, for example. They come into hospital and then suddenly their blood pressure's in their boots because they haven't necessarily been taking them at home because they've been forgetting to take it. Or you see that the sugars are getting higher and higher and higher. They come into hospital, or there's a new carer or new supervision, and the sugars go very low. People might have word finding difficulties. That's not always 100% reliable, but may have problems remembering people's names, putting faces to names, and again, a change over time. People might be withdrawn. They might get things wrong culturally as well. They might be more grumpy and a little bit more disinhibited, saying things that they wouldn't normally say. And sometimes they you know, as a protective mechanism, people will withdraw from activities, because one of the early things to go is new learning. So, you know, you'll see that someone will get won't be able to use a new remote control on the telly, or they get a new phone, or another new item that they can find it difficult to learn the technique to use them. You might find that people pay a little bit less attention to, you know, their outside appearance. They may be losing weight because of problems with cooking. Because again, as we said, those functional aspects of care, it's not like one day you can cook and one day you can't. You see that qualitative loss of those skills over time. So people will tend to, you know, restrict their menu. You know, they cook a couple of things rather than the dozens of things they used to cook. They might rely more on recipes. They might over or under season food rather than just one day cook, next they can't. But that losing weight can sometimes be a bit of a proxy measure for that. And look, you know, you cannot underestimate a reliable bystander history of something just not being right, even if you don't know exactly what that thing is. So the next step around cognitive screening. So we've talked about the case identification, and then we come on to cognitive screening. We've got a number of different tests that we use, and the mini mental state examination tends to be a little bit of the lingua franca of cognitive screens, but you know, it was designed for you know, American men on an inpatient psychiatric ward in the 1960s. So, hey, surprise, surprise, it's not the best test to use in Australia in remote communities. Very heavily dependent on orientation questions, and sometimes you lose someone before you've even got to any of the memory tests because it's really not got any applicability to people. The KICA, or the Kimberley Indigenous Cognitive Assessment Screen, which is a test out of 25, which really is, it only takes about the same time as a mini mental. It's easy enough to do. It has minimal props other than you can use a comb in there, and relies on sort of orientation, memory, and has some language and naming skills in there as well. So works well as a screener, 5 to 10 minutes, and can be performed by any member of the health team. Health workers perform it all the time. It does not need to be a doctor that does it at all. And I think that brings home another point about cognitive testing as well, is the importance of being comfortable with the screen that you use. So, you know, get yourself training, use training videos, do it with a friend to begin with, and understand both the process of the test, but also the results of what you're getting back, because people will want to know how they're going along there as well. And being comfortable with the test means that you get the best performance out of someone. The RUDASH, or Rowland's Universal Dementia Assessment Scale, again, is a good test for culturally and linguistically diverse populations, and has been used extensively across both Australia and indeed Africa and Southeast Asia. And it again has more than the mini mental does on executive function as well, and you know, is a good test to use. in GP land, clock test and the GP cog, which is a clock test plus a basic memory test. Again, that's a good test for executive function and visual spatial skills. And remember, you can formalize the bystander test as well. So that a Kika care is similar to the IQ code or informant questionnaire, where you're actually asking family members about differences that they've noticed and change over time. So you've got an ability to score something as well as your history itself. But it's the familiarity and comfort with using these tools which will see you through. And it's also the team approach. So I seldom make a dementia diagnosis on the first time I see someone. It is about that. Almost the best test you've got is time. A blood test, a scan isn't necessarily going to give you as good a result as actually seeing someone several times over a period of their history. And that's where, the primary care approach to diagnosis is far superior to seeing in the hospital. And, working with the GP and the general practice about making sure that we're not missing something that's making things worse, and also something that's impacting on quality of life. So, this is the comorbidity thing I was talking about earlier. It's not just about whether or not the pain is causing the cognitive impairment. It's about treating the pain so someone's not in pain and they've got a better quality of life. And also making sure every time, and I know I've said this a couple of times before, check the medications, the drugs that, I'm someone as a doctor would rather be stopping tablets than starting them. And, we know that medications can have both an adverse but also a beneficial effect. So treating depression, for example. Important to try and get that bystander history. And as I said, that impact on everyday life is really asking about, doing those things that make you you. There's no point asking about cooking if the person doesn't cook normally. But you get so much information on just a visit to someone's home. It's a tremendous privilege to be able to see someone at home, and keeping your eyes open on a visit there will tell you more than an hour of neuropsych testing, and also gives you an idea of what's going on with the care partner as well. So I might just hand over to Mark again to talk a little bit about some of the barriers to detecting cognitive impairment as well. And I think I've got to press these to bring more up, Mark. So.
Yeah, you can just press them all. Thanks, Eddie.
There you go.
Thanks for that. Yeah, look, I'll just talk to a few of these things here. All of these should be, like relatively common, most of you, I'm sure, will be aware of. But differentiating between normal aging and dementia, and look, in my experience, there's a number of things around this. Partly, people in community just tend to take care of their family members. So this includes like some severe disability as well, where people haven't really been reported. Families just take care of them. And so people think family members are aging and need more caring, just normally need more caring. So just automatically family members kind of jump in and do bits and pieces. Often it's hard to, some of the educations with families, just making sure they can really identify things and understand why these things are happening. And there is certainly beliefs that diagnosis won't make a difference, and particularly some of that stuff that Eddie talked about earlier around prevention is really pertinent, I think. The fear and stigma, once again, is a big one. The lack of insight from the patient obviously is an issue, and stoicism. And look, you kind of see all of those things really in our clients. The other things that you might have trouble with, though, is getting. Often our families don't like to kind of dob in the oldies. If you get what I mean, it's kind of can feel a little bit like they're breaking a code or something like that by talking about how mum's really going or how grandma's really going, etc. So have to be a bit sensitive about how you approach that kind of stuff, but really look for cues from patients, particularly and family members, because look, as we heard earlier, like if an elder starts getting a bit more aggressive, and they're the ones that are kind of in in charge of training our younger people, that sets up a whole bad scene for that younger person later in life, because that's the person who's training them. So suddenly someone being aggressive or paranoid or a bit, over the top is very strange for them. So in a lot of ways, the family's really a major connector. And as I said earlier, from the results of the MK study, one of the big studies that we've been doing on cultural determinants so far, the things we've been looking at have been pretty simple things, but like time being on countries, time spent speaking language, being involved in ceremonies, etc. And those kind of things certainly have a positive effect on people's well-being from the studies that we've done so far. It looks actually like a dose response to all of those cultural things. So once again, I think it's really important to help families understand that they don't have to exclude oldies from cultural events and cultural ceremonies, things like that. In actual fact, it may even be in some ways therapeutic. So all of those things I think are really important. From the health service perspective, the lack of knowledge is certainly still an issue in lots of special areas, complex care and other conditions. And look, you go to any primary healthcare service that takes care of large, populations of Aboriginal Islander people, and you'll find a lot of conditions in the one person. So for health services, prioritising conditions related to ageing and cognition take a little bit of a drive at a service level, so kind of raising these things, profiling the service takes a bit of championing in and kind of clinical leadership there as well. The difficulty in raising sensitive issues with elders particularly, I think, is an issue, and probably as much a cultural issue as it is anything else, particularly for our health workers and Indigenous practitioners specifically, and misdiagnosis obviously is another one. But there's a couple of things I think services can think through. One, as I said, is identifying champions within the service, whether they're health workers who have relatives or allied health or nurses or GPs who have a special interest. But a driver within your service really helps to change the structure and the approach. The other thing I think what Eddie was talking about earlier around the 715, so that's the annual adult health check for every Aboriginal person that's well incentivised for GPs and practices. Once you get these kinds of screening questions in those, it becomes a lot more systematised as well. And it's not about whether the practitioner wants to do it or not, it's kind of in the system. And so it gets a lot better covered. So those things I think are really useful and interesting. Look, this whole idea around the approach and how you start contextualising your thinking around this and around patients you may be taking care of, and even having that conversation. And sometimes I have that difficulty with that conversation with elders who I have lots and lots of respect for. Not that I don't have respect for everyone, but there are people who you don't want to kind of be asking the wrong questions the wrong way at the wrong time. So it really is important to get a bit of context around people. I also find it's interesting with this age group to find out if people have been have had lots of bad experiences on the Aboriginal Protection Act, etc., because they have kind of different ways of dealing and coping and talking to people, and often they'll know what you want to hear and answer the way that you want to hear, because they're used to that, having lived under those kind of conditions in the past, socially and legally. So all these things about preparing well, I think, is about thinking about context and where people's history is and their family history and their early childhood history. The feeling comfortable, as we all know, with the tests, so making sure that if you are using anything as props, to have them there and be able to use them. The time and space is really useful, because once again, when you're talking to some of these older clients in a busy clinic, it's just annoying when there isn't time and space, as many of you will know. Getting interrupted all the time doesn't help with any of these kinds of screening. So really important that to have time and space and make sure that's available. Explaining what you're doing and why is really important, once again, and in a way that people can understand. Often it's useful to have an Aboriginal health worker or health practitioner available, so they can explain things properly. But also it's useful to have a translator if you're working remotely, particularly, or with people who have English as their second, third, or fourth language. It can really help you to be sure that you're both talking about the same things. It's really, really important, if you need it, that is. And the other thing is all these positive aspects. I think it's really important to get that across as well. There's lots of things that we can do to help your brain health. So this isn't a big negative diagnosis thing. This is about how we can optimize your life from now on in. So that's, I think, back to Eddie.
Yeah, thanks, Mark. And I think it's really, I think that supporting detection idea within your health service is about thinking about brain health. So having that on your mind, being aware of those risk factors we talked about, and we saw in that lovely diagram of the river of prevention, especially in 50+ patients, taking notice of concern. So not dismissing a self-reported issue with memory or something coming from the family, but taking it seriously and then taking the next step to screen. Ask those questions about, have you noticed a problem with your memory, or has anyone in your family been worried about your memory? And do something if you get that reports back, so respond. Using standardized tools has its place. It allows you to talk with others about a definite level of issues, and using health assessments and chronic disease care plans, referrals and recalls, and all the stuff that you're comfortable with using within the health service anyway. So what happened next with Molly and Frank? Well, I think the expression is to stay tuned for the next episode, but the future webinars will tell us more about this. But Karen, the health worker, did do an annual health assessment, which included the KICA screen, which showed that there were some obvious problems. The KICA score was 18 out of 25, so below the cutoff there of 22/23. And the KICA carer was higher than the cutoff of 2 out of 16, so suggesting that there were questions that had been of memory that had been noticed by family as well. These were discussed with both Aunty Molly and Frank, and with a GP as well, and stuff was done. So dementia screening bloods are around ruling things out rather than making the diagnosis, but also making sure of associated illnesses. And the brain scan gives us an idea of, I guess, the architecture of the brain, and helps us see if there's been any strokes or any shrinkage of particular key areas. And we had a look at Aunty Molly's medications and stopped a few of them, I would hope. So Karen was nominated as the main point of contact within the health service for Aunty and Frank. And Aunty was also referred to a specialist, and that specialist diagnosed mild Alzheimer's disease, and gave a good discussion on the diagnosis with both Aunty Molly and Frank as well. Medications for dementia were started, with Frank monitoring her tablets, and Karen also spent the time to yarn with Frank about both the dementia, but also about how to promote independence and how to, again, make sure that Aunty Molly lives a full and supported life. So we shall see next episode with what happens next time. Now, I will pass over to Dina, who's going to share some questions, but I'll leave this up for a minute. As we said, you're going to get copies of the presentation as part of attending today, but there's some useful resources there, which Dina will give you more information before we go on to the questions.